crucial to effectively control the cancer chemotherapy-induced nausea and vomiting. If it's treated uncontrolled, or a prolonged chemotherapy-induced nausea and vomiting has a potential to cause it may cause dehydration, electrolyte imbalance. It may lead to muscular effect and mental consequences, malnutrition and esophageal tears. It may lead to impaired health-related quality of life, negative impact on the activity of quality of life, daily life. It may lead to discontinuation of anti-cancer therapy, and it may nightly lead to the morbidity or the mortality. It will lead to the delays in discharge from hospital, and ultimately it will increase the cost to the healthcare system and the treatment and to the patient. So now, what impact on physical health? CINV affects the physical health of patient in a number of ways. Interestingly, patients can lose or gain weight during chemotherapy. Some patients are unable to eat as they may experience the loss of appetite, concomitant gastritis or reflux symptoms. It may lead to constipation. Neurological side effects such as dystonic reactions may lead to fatigue as well. The impact on mental health is should never be overlooked. Mental health is always a challenge for healthcare providers. Patient may mental health patient who are receiving chemotherapy are already anxious. Treatment has sufficient impact on the conduct of daily life, so they experience the anxiety, depression, hopelessness and depression. Now we will talk about the classification of emetogenic potential on the basis of emetogenic potentials. The category is divided into high emetic risk factors. The medicines are divided into high risk factors. The chemotherapeutic agent that may cause emesis greater than 90% of 90%, it categorized under the high emetic risk. The drugs that cause moderate emetic risk will be 30 to 90%. And the drugs causing low emetogenic will be 10 to 30%. And minimal emetic effect, fewer than 10% of patients experiencing the acute emesis. Now we will talk about the agents that are high emetic, that have the high emetic risk, moderate emetic risk, and the minimal and low emetic risk. High emetic risk agents could be the cisplatin, cyclophosphamide, dosing greater than 1500 milligram, doxorubicin greater than or equal to 60 milligram per meter square, epirubicin greater than 90 milligram, ifosfamide, and carboplatin. In moderate emetic risk factors, the drugs include doxorubicin in lower doses, epirubicin, ifosfamide, irinotecan, methotrexate, and so on. Now, moving towards the drugs that cause low emetic risk. It contains so many drugs. For example, gemcitabine, cytarabine, low doses, 100 milligram per meter squares to 200 milligram per meter squares. Pemetrexate, low dose methotrexate, paclitaxel, albumin-bind paclitaxel, etc. For minimal emetic risk, it contains cetuximab, etc. Why it is necessary why it is necessary for effective management of chemotherapy-induced nausea and vomiting? We should know we should be aware of the awareness of risk factors and anticipating the type of emesis. It should contain the proper medical health. Understanding the pathophysiology is the main part in treating the management of in treating cancer-induced nausea and vomiting. We have so many guidelines for antiemetics management, mainly the Multinational Association of Supportive Cancer, Care in Cancer, European Society of Medical Oncology, American Society of Clinical Oncology, and NCCN, National Comprehensive Cancer Network. Now, talk about the pharmacological classes and for the management of chemotherapy-induced nausea and vomiting. First, we have corticosteroids. Dexamethasone was the first major antiemetic agent used for CINV prevention. This highly effective drug helps to prevent emesis and can be useful in rescue settings in patients receiving minimal or moderate emetogenic chemotherapy. Although dexamethasone is an essential and effective component in combination regimen for management of CINV. Alone, it is less effective for moderate to high emetogenic chemotherapy. Second category, we have the 5-hydroxytryptamine receptor antagonist. This drug serves as an antagonist for 5-HT3 receptors, which are located on the vagal afferent neurons in the gastrointestinal tract and the central nervous system. Now, what is the central mechanism? Central mechanisms are also involved as 5-HT receptors are located in the CNS in the chemoreceptor trigger zone for emesis. Blocking the central 5-HT receptor prevents the emetogenic effect of serotonin. Therefore, blocking both peripheral and central 5-HT3 receptors prevent the emetogenic effect of serotonin. We have two generations for 5-HT3 receptors. First generation, we have the ondansetron, granisetron, belasitron. The main side effect of first generation 5-HT receptors are the ECG or the QTC ECG changes or the QTC intervals. In second generation, we have different drugs, mainly the palanositron. The second generation palanositron has a structural difference that confers more selective binding to 5-HT3 receptors and extended half-life of approximately 40 hours than compared with the 4 hours of ondansetron and 9 hours of granisetron, that is the first generation 5-HT receptor. More interestingly, it has no QTC prolongation in seen with the palanositron. Now, moving towards the next category, that is the neurokinin receptor 1. Substance P is a neuropeptide found in high concentration in the vomiting center in the brain, as Dr. Lubna Sanim told us about the pathophysiology of receptors. Binding of substance P to the neurokinin 1 receptor promotes emesis. NKI receptors antagonists have been developed as antiemetic agent that selectively block the binding of substance P to the NKI receptor. NKI receptors antagonists, the newest class of antiemetic therapy. It contains the aprepitant, fosaprepitant, and neutropitant. Aprepitant, it used along with the 5-HT receptor antagonist and the dexamethasone. Fosaprepitant is a prodrug of aprepitant administered intravenously 30 minutes before the chemotherapy, as fosaprepitant is converted to aprepitant 30 minutes post-injection and provide the same duration of effect as the aprepitant given. For neutropitant is a new formulation, and it comes in the fixed dose combination of palanositron plus neutropitant. We have some other antiemetic agents like benzodiazepine. It contains the lorazepam. Lorazepam can help with anxiety, anticipatory, CINV, and sleep disturbance. It has a shorter half-life of 14 hours. Cannabinoids, I will discuss it later on. Then the metoclopramide, chlorpromazine, prophylaxis for the minimally emetogenic chemotherapy agent. Then we have olanzapine. Olanzapine is a second generation antipsychotic that blocks 5-HT receptor and dopamine. Optimal dose of prophylactic olanzapine is not yet established. Varies from 10 milligram to 5 milligram to 10 milligram, because the safety data in elderly patient is not yet established. And we have to be concerned with patients like having the type 2 diabetes, older age, hyperglycemic patients. Now, we will talk about the clinical trial of NEPA. NEPA is a fixed dose combination of NKI receptor antagonist, nitipetant, and the 5-HT3 receptor antagonist, palansitron. It has some benefits. The formulation enables patient to take a single capsule with 2 active ingredients, adding corticosteroids as needed. The half-life of nitipetant is approximately 80 hours compared with the 9 to 13 hours of aprepitant. In my talk, I will discuss about these two guidelines, that is the NCCI 2023 and the Multinational Association of Supportive Care in Cancer. Moving from the minimal to low to minimal antiemetic, low to minimal risk drugs, then we will talk about the high risk factors. For low emetogenic drugs, we don't need antiemetic drugs routinely before chemotherapy, as if patient do not have any history of nausea and vomiting. For the prevention of, if the patient is receiving low emetogenic chemotherapy, then a single agent such as dexamethasone, 5-HT receptor, or a metoclopramide is enough in the prophylaxis setting. Now talk about the delayed nausea and vomiting. Patients receiving low or minimal emetogenic chemotherapy. Same no antiemetic should be administered for prevention of delayed nausea and vomiting induced by low or minimal emetogenic chemotherapy. Now talking about the moderate emetic risk anti-cancer agents. In acute setting for moderately emetogenic chemotherapy, 5-HT3 receptor antagonist plus dexamethasone is recommended. It means we can use first generation or either second generation 5-HT receptor, that is the ondansetron, granisetron, dalasetron, and the palansitron, or plus dexamethasone. For delayed nausea and vomiting in moderately emetogenic chemotherapy, like oxaliplatin, anthracycline, cyclophosphamide, we have to use the dexamethasone on day 2 and day 3 can be considered. Talking about the high emetic risk factors, high emetic anti-cancer agents. For prevention of acute nausea and vomiting, for non-anthracycline cyclophosphamide chemotherapy, we have to use 3-drug regimen that includes a single dose of 5-HT receptor antagonist plus dexamethasone and the NK1 receptor antagonist. It could be aprepitant, fosaprepitant, dutapitant, or the rolapitant. Rolapitant is currently not in use as banned by the FDA. It causes severe side effects in patients, causing the heart attack, cardiac arrhythmias, etc. It should be given before chemotherapy. For the prevention of delayed nausea and vomiting, patients receiving non-anthracycline cyclophosphamide chemotherapy in delayed setting, we have to use a combination of NK1 receptor antagonist, 5-HT receptor antagonist, dexamethasone to prevent acute nausea and vomiting. Dexamethasone is suggested to use on the day 2 and day 3. Now, if we are using aprepitant, it should be 120 milligram on day 1 and day 2 and day 3, 80 milligram. Now, talk about the prevention of acute nausea and vomiting for anthracycline and cyclophosphamide-based chemotherapy. Usually in breast cancer, the DDAC protocols. We have to use a single agent, same 5-HT receptor antagonist, dexamethasone, and NK1 receptor. Now, talking about the delayed settings, we have to use a combination of 5-HT receptor antagonist, dexamethasone, and NK1 receptor antagonist to prevent acute nausea and vomiting. Aprepitant or dexamethasone should be used on day 2 or day 3 or none. If fosaprepitant, nitipetant, or rolapitant has been used in day 1. For olanzapine, olanzapine may be considered with 5-HT receptor antagonist plus dexamethasone. Now, talk about the patient who are receiving the multi-day cisplatin. Patients who are receiving multiple days cisplatin should receive 5-HT receptor antagonist plus dexamethasone plus aprepitant for acute nausea and vomiting, and dexamethasone for delayed nausea and vomiting. What about the prevention of nausea and vomiting in patients receiving high dose chemotherapy? It's almost same. We have to give 5-HT receptor antagonist plus dexamethasone and aprepitant. 125 milligram orally on day 1, 80 milligram orally on day 2 and day 3. Now talk about the antiemetic drugs and their classes. Just a second. 5-HT receptor antagonist for acute MSS, it's potentially used for acute MSS, ondansetron and palansitron. NK1 receptor, that is the aprepitant and phosphaprepitant, it's mainly used for delayed MSS. Multiple steroids, it can be used for acute plus delayed MSS. The D2 receptor, metoclopramide, it's same efficacy for acute and delayed MSS. Benzodiazepine, the GABA chloride channel complex, it's have the same efficacy for both delayed and acute MSS. Now, it's a summary for acute nausea and vomiting. For non-AC, we have to use a 5-HT receptor plus dexamethasone plus NK1 receptor plus minus olanzapine, as its data is not established yet. For high AC, anthracycline cyclophosphamide based chemotherapy, same regimen will be followed. For carboplatin, olanzapine is not recommended. Whether we have to use 5-HT receptor, dexamethasone, and NK1. For moderate hematogenic chemotherapies, only 5-HT receptor and dexamethasone is much enough. For low hematogenic chemotherapy agents, only one agent is enough. That will be a 5-HT receptor or DEXA or the dopamine receptor antagonist. For minimal hematogenic drugs, there is no routine prophylaxis is recommended. In delayed setting, for a high non-anthracycline cyclophosphamide based chemotherapy, DEXA or aprepitant is recommended. Aprepitant, if aprepitant 125 for acute. For high anthracycline cyclophosphamide chemotherapy, none are aprepitant. If aprepitant is used, then we use 125 milligram on day 1, 80 milligram on day 2, and 80 milligram on day 3. For carboplatin based chemotherapy, only aprepitant 125 milligram for acute or for delayed setting, nothing is required. Oxaliplatin, anthracycline, or cyclophosphamide irinotecan based chemotherapy. In delayed setting, only DEXA can be considered. If patient is complaining of nausea or MSS, or you taking the oxaliplatin or irinotecan, only DEXA can be used. For moderate, no routine delayed setting, no routine prophylaxis is recommended. For minimal to low hematogenic drugs in delayed setting, no routine prophylaxis is recommended. Now talking about the breakthrough treatment of anti-cancer therapy, nausea and vomiting. We have some guidelines of for breakthrough nausea and vomiting as well. The available evidence of for breakthrough nausea and vomiting suggests the use of olanzapine. Olanzapine is recommended only in breakthrough nausea and vomiting. Breakthrough nausea and vomiting is defined already by Dr. Lumna Salim. Now, talking about the anticipatory or the learned response chemotherapy agent. For anticipatory nausea and vomiting, best approach is for nausea and vomiting is to control acute or delayed setting so that the patient will not experience or will not habitual of the next anticipatory nausea or vomiting. Now, talking about the recommended doses of serotonin receptor antagonist for acute nausea and vomiting. Ondansetron, it's available in IV and oral formulation. For IV, its dose is 8 milligram. Maximum daily dose is 32 milligram. We have to consider some points while using the ondansetron. Ondansetron, if we use ondansetron, we give the ondansetron faster, less than 15 minutes. It will cause the cardiac dysrhythmias, ECG changes. So we have to be careful. And a maximum dose for ondansetron is 18 to 32 mg. For oral, it's maximum 16 milligram. Granisetron, it's available in IV and oral formulation. IV is 1 milligram, and the oral is 2 milligram. Dolasetron orally, it's available in 100 milligram. For planasetron, IV formulation is 0.25 to oral is 0.5. If we talk about the dexamethasone, for high risk patient in acute emesis, we have to use 20 milligram once, 12 milligram when used with fosaprepitant or neutropatine. For delayed emesis, 8 milligram BID for 3 to 4 days is much enough. In case of moderate risk, acute emesis, 8 milligram once it's enough. For delayed, we have to give it for 2 to 3 days. For low risk, 4 to 8 mg once daily is enough. NK1 receptor for aprepitant, fosaprepitant. In acute emesis, aprepitant, the dose of aprepitant remains same. That is the 125 milligram once on the day of chemotherapy, then 80 milligram on day 2 and day 3. Fosaprepitant, it will be 150 milligram once daily. Now talking about the antiemetic regimens for prophylaxis of radiation-induced nausea and vomiting. In high frequency of emesis greater than 90%, the patient receiving radiation side, that will be the total body radiation, we have to give 5-HT receptor plus dexamethasone. For moderate, radiation side will be the upper abdomen, crinospinal. 5-HT receptor antagonist plus optional dexamethasone is recommended. For low frequency of emesis, 10 to 30%, radiation side will be the brain, head and neck, thorax and pelvis. As per need, rescue therapy with a single agent, it could be 5-HT receptor antagonist, dexamethasone, or dopamine receptor antagonist. Dexamethasone preferred agent for brain irradiation. For minimal frequency.
Sorry for interrupting you. We just have 2 more minutes. Sorry, because we are running out of time. Thank you so much.
Okay. Now, how to manage poorly controlled chemotherapy-induced nausea and vomiting? It is very necessary to exclude these if we are following all the antiemetic guidelines and still patient is complaining of the nausea and vomiting, then we have to see whether the patient is using the opioid analgesics. Certain antibiotics may cause CINV, central nervous system metastasis. Hypercalcemia, GI obstruction may lead to the CINV. Other measures that we can obtain is the addition of the benzodiazepine, olanzapine, dopaminergic agents, and substituting high dose IV metoclopramide. Alteration in chemotherapy can also be done. Like we can change the protocol from multiple days therapy to the single day. We can reduce the infusion time, substitute the less hematogenic agent. If the tumor is not, if there is no side effect on the tumor. What about the cannabinoids or marijuana? No medical or legal concern approved, so it's not recommended for the management of CINV. Now talking about the non-pharmacological strategies, one can cognitive distraction plays an important role as a non-pharmacological strategies in controlling CINV. Exercise, hypnosis, acupuncture, ginger, transcutaneous electric nerve responses. Now, I really want to talk about the role of pharmacist in managing the CINV. Pharmacist plays an important role and active in patient to prevent and treat the most debilitating side effect of chemotherapy. One study showed that if we are adhere to the guideline, then the ratio for the for the experience of chemotherapy induced nausea and vomiting will be low. Patient experience breakthrough CINV should be switched to a different therapeutic class to treat the CINV. If patients are struggling with the cost burden of CINV, it may be helpful to consider less expensive. Pharmacists should educate patient about CINV and the various non-pharmacological strategies. Now, what is the take-home message? Incorporating the principle of CINV management is critical to success of cancer therapy. The most essential component of CINV management is the appropriate use of prophylaxis. Effective prophylaxis is starting with the first cycle of therapy so that patient would not experience the anticipated nausea and vomiting. So we have second point will be the CINV management is the treatment strategy may need to be modified on the patient individual basis, not on the institutional basis. And the goal is to have zero tolerance in regarding the prevention of the nausea and vomiting. All from my side. Thank you.
Thank you very much for this interesting topic, Dr. Madiha.
You are welcome.